been in and out of mental hospitals. The last time, she stayed 3 years. The patient comes from what we generally call family. Her childhood was uneventful, with no injuries to the brain as far as could be determined. Elizabeth's parents report her alert as a child, with no obvious mental or physical abnormality. 22 years ago, Elizabeth began a style of behavior which has brought her to this room today. A type of behavior characterized mostly by anxiety and the repetition of actions, the necessity to do certain things at certain times. It's called compulsive behavior and is similar to the child who feels he must walk on the cracks in the sidewalk to break the devil's dishes, as the game goes in some parts of the country. But with much greater urgency in Elizabeth's case, compulsions to act in sometimes unpredictable and unnatural ways were so strong and interfered with her life so much she needed to be hospitalized. Over the years of treatment, she became more withdrawn and did not respond to methods of treatment which often helped the mentally ill. Here sits Elizabeth S., preparing for an experience with possibly profound effects upon her life. This program is divided into 2 parts, psychosurgery and shock therapy, 2 of a number of approaches in treating mental illness. We have grouped psychosurgery and shock therapy together, for they are similar in one respect. The treatment is applied directly to the brain. In psychosurgery, holes are made through the skull to destroy nerve fibers in the brain, while in shock therapy, a convulsion or coma is brought on by chemical or electrical stimulation of the brain without opening the skull. Since the brain is the focus of our attention today, let's examine it for just a few moments. To greatly simplify things, the human brain is composed of higher and lower centers. One lower center, or primitive brain, is called the thalamus. It is here that sensations and feelings are brought into consciousness. This portion of the human brain appears to supply man's basic drives, such as the drive for food, elimination, self-protection, sex, and others. The primitive brain has direct connections with the cortex, that part of the brain most fully developed in man and which covers the primitive brain like a mantle. The cortex modifies the basic drives furnished by the primitive brain, socializing them, so to speak, as well as providing for other human functions such as intelligence, memory, speech, sight, etc. We are interested today in the nerve fibers which run from the thalamus to the frontal lobes, these projections here at the front part of the cortex. The frontal lobes are the centers for the more personal human functions of self-awareness and foresight, functions severely impaired in the mentally ill. Knowing this, many have thought that a faulty relationship between the primitive brain and the frontal lobes may have something to do with mental illness, perhaps a structural or chemical lack of balance between the two. Some medical men suggested, why not break the connection between the two? What would happen then? Researchers such as Fulton and Jacobson did this by cutting brain nerve fibers in chimpanzees and noted a carefree attitude as a result. The animals appeared no longer upset by failure in problems presented them. Then Dr. Egas Moniz, a Portuguese neurologist, proposed an operation upon the frontal lobes of mental patients. Under Moniz's direction in 1935, an associate drilled holes in the skull and cut these brain pathways. Of the first 20 patients reported on, 7 recovered and 7 improved. The remainder were unchanged. This psychosurgical technique, called a prefrontal lobotomy, was slow in acceptance because of the fear of undesirable personality changes. Convulsions, irresponsibility, and laziness were reported in some cases, making the use of this method a last resort type of treatment. The first prefrontal lobotomy in the United States was undertaken in 1936 by Dr. James Watts, a neurosurgeon, and Dr. Walter Freeman, a neurologist. Dr. Freeman is with us today to discuss the surgical approach to treating the mentally ill. Dr. Freeman, psychosurgery, or lobotomy as it's often called, is perhaps one of the most controversial ways of approaching the treatment of the mentally ill. Why is this so?
Mr. Palmer, a number of psychiatrists and others are opposed to cutting into the brain for what they feel are ethical or moral reasons. Now, I can't discuss that attitude because it's an emotional one. More understandable, I believe, is the attitude of others. Their main objection is that psychosurgery or lobotomy of any kind changes the patient's personality. Now, that's true, but there are good changes as well as bad ones. And the bad ones can be minimized or avoided by cutting just enough fibers and no more. When other methods of treatment have failed, serious consideration is given to one or another type of psychosurgery. I might note, of course, that psychosurgery is better in certain types of patients than in others, And this must first be medically determined very carefully.
How many lobotomies have been performed in this country?
Well, considering those operations done on patients who are suffering severe pain from cancer and so on, probably 25,000.
And what types of lobotomies are there, Doctor?
There are a number of them. I don't think we have a chance to go into all of them, but on this chart I can demonstrate a few of them. The first type of lobotomy had the instrument inserted in about this plane and sever the fibers going from the thalamus to the frontal lobe in its mid-portion. Now, thalamotomy consisted in inserting an electrocoagulating instrument into the thalamus about in this location, deep, and destroying nerve cells at their origin. Another operation called topectomy consisted in removing the cortex out in the anterior part, the frontal pole of the brain. Now, among those operations that have been used to destroy the fibers, there are a variety. The simplest of these is the transorbital lobotomy, in which an instrument is inserted beneath the eyelid and goes up and severs the fibers in the same location. This instrument, which I demonstrate here, has a number of marks on the shaft, and this goes down to approximately the 7-centimeter mark here. The instrument is moved in a sort of Z fashion in order to sever the fibers that are important in this connection. Now, there's one other type of lobotomy that we can illustrate here. It was shown on the patient undergoing the shaving of the head. This is the Grantham type of lobotomy. Now, I think you can see that the holes have been completed through the skull and the scalp. And now this is the instrument, the needle, electrode needle, that is to be inserted into the brain.
There they are right now.
They're inserted into the brain. Now they're going to be measured most carefully, because this is an extremely accurate method of placing the incisions. I shouldn't call them incisions. I should rather call them areas of coagulation, because the current is turned on, and after 25 or 30 seconds, there's a destruction of tissue, probably, about a quarter of an inch, half an inch in diameter. As you can see in this picture, the surgeon is maintaining the instrument in the proper location. Now the operation is finished, just showing up.
Can you show us, perhaps in a diagram form, what this looks like, the Grantham type?
This is a diagram showing where the instruments have gone. As you can see, the hole in the skull and the scalp, and the instrument is inserted down close to the base of the frontal lobe, coagulating first the first area and then the second area. There's no destruction, apparently, of the cortex itself. And then on the x-rays, which I show here, you can see that the instrument placement is extremely accurate. Those things go down within a millimeter or two.
Could you give us some ideas as to the results of psychosurgery, Doctor?
Yes, I can. I brought some photographs along with me of patients before and after operation. Although facial expression is no accurate indication of the patient's actual condition, it does give an impression of change. I'd like especially to point out the anxious and strained look prior to lobotomy and the difference in that look following the operation. This first patient was a middle-aged lady, and I think you can see that there's been a remarkable change in her before and after operation. In the second patient, here we notice the drooping of the eyelids before operation, and after the operation has been completed, a rather gay and carefree attitude which persisted and has allowed this lady to go back into society and perform very satisfactorily. A third patient shown here is a middle-aged lady who was again suffering extreme depression and anxiety, and these pictures show the instrument in place under the eyelid. Remember, in this transorbital lobotomy, there's no cutting into the skin or scalp, and this Z-shaped incision, I think you can imagine, but after the operation, this patient has got along very satisfactorily and has been working, doing her housework for the past 10 years or so.
What about the future of lobotomy, Doctor?
Psychosurgery for mental disorders was widely used between 1949 and 1953. It fell off then when the tranquilizing drugs were introduced. Lobotomy wasn't too satisfactory for those violent patients anyhow, and the drugs proved better. However, some patients with endless suffering from severe ideas of shame, guilt, fear, as well as unbearable pain, are relieved only by drugs that dull their senses. Now, lobotomy properly performed on these patients may restore self-confidence and peace of mind with little personality disturbance. For certain patients, lobotomy will continue to be used until a substitute method is found to ease their suffering. Meanwhile, there are a number of techniques which, though still experimental, may be able to destroy with pinpoint accuracy certain localized areas in the brain with a decrease in the number and severity of undesirable effects.
Could you tell us of some of those?
Yes, there's one by Dr. Insulin, which uses the ultrasonic sound beam to destroy a tissue. The sound beams are directed through the brain coverings and concentrated within the brain at the precise area to be affected. Another approach recently in the news is the use of a proton beam directed at a certain place in the brain to destroy tissue. This can be done without even opening the skull. Swedish surgeons, as well as a research team at the University of California, have done some remarkable work in this field. The aim of the neurosurgeon and the neurologist when dealing with mental illness is to develop a technique which will be effective with the least damage to the patient. I'd like to repeat what we said earlier, Mr. Palmer, if I may, and that is that psychosurgery has shown its use most dramatically with a certain type of mentally ill patient. Without the types of patients, it has little, if any, value. As with any surgical operation, however, caution and good medical investigation should precede a decision to do any psychosurgery.
Thank you very much, Dr. Freeman, for giving us this valuable information on psychosurgical techniques. Psychosurgery is considered an organic or physical approach to mental illness. Actual tissues, fibers, and cells of the patient are involved, in contrast to the psychological approach when we deal with the emotions, attitudes, and feelings. Another such organic outlook in psychiatry is the use of the shock therapies. We have asked Dr. Douglas Goldman to appear with us to give us his views on these treatment methods. Dr. Goldman is clinical director of Longview State Hospital, one of the largest state mental institutions in the country, and was one of the pioneers in the use of electroshock therapy. Dr. Goldman, what is electroshock therapy?
Well, so-called electroshock therapy is a method of treating certain mental illnesses by passing electric current through the brain. Like all treatment, this is carefully measured and timed to be safe and effective. Shock therapy is often thought to be analogous to treatments of centuries ago when fright and intimidation were used, as in this illustration of a physician of long ago threatening a group of women with a hot branding iron to cure them of their hysteria. Another ingenious method of frightening patients suddenly was this early device for dropping a patient unexpectedly into a vat of ice-cold water. This was to provide a sudden shock in an attempt to influence his mental illness. These methods and other techniques of torture are in no way the forerunners of modern shock therapy. They deliberately produce psychologic fear and anxiety in conscious patients. Those undergoing shock therapies today are under influence of an anesthetic and spared any unpleasant aspects of the treatment. The comparison of present-day shock therapies with medieval tortures is probably due to the use of the word shock. We may rather speak of pharmacologic treatment, which is the use of drugs, and electric treatment, according to the method used.
When does the history of pharmacologic and electric treatments actually begin, Doctor?
Pharmacologic treatment of mental illness probably began in the time of Hippocrates or earlier. In modern times, continuous sleep was used in 1922 as a treatment for mental illness, and it still is used in some places. And most psychiatric historians agree continuous sleep can be considered the most important predecessor of present-day pharmacologic and electric treatment. However, these methods of treatment as we now know them began around 1931 when the use of insulin was first introduced in the treatment of mental illness. A Viennese psychiatrist, Dr. Manfred Sackel, made a point of observing the reaction of mental patients to the injection of insulin, a substance usually used in treatment of diabetes. Entirely by accident, some patients became unconscious from excessive drop in blood sugar level and comatose. When brought out of the coma, the patients appeared to show signs of improvement in the symptoms of their mental illness. After Sackel reported his carefully documented observations, insulin therapy caught on quickly and within a few years was being practiced extensively in the United States and throughout the world. A Hungarian psychiatrist, almost at the same time, A man named von Meduna, who is now in the United States, found that he could artificially produce seizures and unconsciousness by injecting camphor into mental patients. The convulsions or seizures the patients experienced had a beneficial effect upon their mental condition. Later, von Meduna used a drug called Metrazol, which had a much more controllable effect with better results. In 1938, use of electric current was introduced by two Italian researchers, Cerletti and Bini, and quickly replaced the use of Metrazol and other chemicals. Electroconvulsive therapy, as it may be called, became the most widely used therapy in psychiatry. Naturally, the years brought many technical improvements, but the basic technique is essentially the same now.
As clinical director, Dr. Goldman, have you made use of photography, as some hospitals have, to show the results of their therapies?
Yes, we did, and I would like to show you some of the films depicting the use of Metrazol, insulin, and electricity. I should like to emphasize the careful medical nature of the procedures. Patients are all examined prior to treatment, just as before any procedure requiring anesthesia, and are under anesthesia while any unpleasant part of the treatment is in progress. Here we see a patient being prepared for Metrazol therapy. This film dates to 1937. We see the seizure movements evident in the film. The seizures last from 20 to 40 seconds, and then the patient drops off to sleep.
Is there any danger involved in
The dangers of these treatments are minimal, probably less even than in what we might call a mild procedure such as a dental extraction. Dangers are rarely encountered. This patient is also undergoing Metrazol therapy. We see the use of the mouth prop to protect the tongue, the profuse perspiration which follows the muscular exertions involved. Here we see the insulin therapy clinic where insulin coma was practiced. We would treat up to 24 patients at one time under careful medical supervision. Here is all the apparatus that was needed. Here is a patient in deep coma, showing deep respirations, heavy sweating. The deep respirations were rather loud and could be heard throughout the clinic, of course.
Is this a deeper coma she is in here?
But she is gradually approaching the depth that is desired for treatment purposes. The reflexes change, certain movements change, and these are the evidences of coma. This is the termination procedure in which sugar is introduced into the stomach through this tube. The quantity is carefully measured, and the patient will awaken within 5 to 10 minutes. This is a more modern ward at the hospital. We are here depicting a very depressed patient, a patient who characteristically has had a number of episodes of depression. There is, of course, in depression, suicide risk. Patients feel unworthy, unwanted, feel that their organs are improperly developed and not functioning. They wish to have nothing to do with any human being, and probably characteristically not even with themselves. Some depressed patients, of course, are difficult to manage. Some are mildly tractable. The patient is being subjected here to one of the procedures required in the diagnostic examination before any treatment is begun, the psychiatric interview. Diagnosis always must precede therapy. The patient, of course, being depressed, hardly mumbles answers to the physician's questions. The physician, of course, has a very sympathetic attitude in spite of this. Here we see one of the procedures that is very important in modern psychiatry, electroencephalography, the determination of the brain waves. We record from a number of areas of the brain the electrical activity of the brain cells under the scalp electrodes. Patients are subjected to careful physical examination. The physician is here examining the heart. This, of course, must be in good condition before therapy can be carried out safely.
There's strain on the heart under electroshock?
Well, as in any procedure requiring anesthesia, there is a strain on the heart, not excessive, of course. Here we are examining the reflexes and the neuromuscular changes to determine the adequacy of the nervous system. One of the laboratory procedures that is carried out is examination of the spinal fluid, and here we see the spinal puncture being done. This is a relatively simple procedure and quite painless in skillful hands. This is the electric shock therapy unit. The patient is brought in. The nurses have a kindly and friendly attitude. We try to choose those whose personalities are attractive and not threatening to depressed patients for this purpose. The electrodes are being applied here. To make contact between the skin and the electrode, salt paste, which is similar to what is used in electrocardiographic examinations, is used. The treatment is carefully measured electrically by setting the various dials of the machine that you see here illustrated, and the timing is carried out very accurately with a stopwatch. The mouth prop is used to protect the tongue, as you have seen previously. The muscle movements of the seizure of the electroshock are illustrated. They are, of course, relatively mild in modern treatment.
That's all there is to it?
That is about all there is to it. It's that simple and safe. After the treatment is completed, the patient is likely to sleep for from 5 minutes to a half hour and is usually considerably relaxed following the treatment, even though the actual depressive manifestations may require several treatments for relief.
But there's usually immediate response?
There is some immediate response in some patients. Some patients almost miraculously complete relief from the depression, even from 1 or 2 treatments. We give the patient a chance to relax in quiet and solitude for a short time following the treatment. This shows the degree of relaxation and quiet with the patient asleep. Here is the patient several weeks later, considerably improved. She is interested in reading, takes an interest in her surroundings, and is even able to smile at other people. In other words, she is very much relieved from her depression.
Those were interesting films, Dr. Goldman. Tell me, do we know what actually happens within the brain as a result of this treatment?
Actually, there is no clear knowledge in spite of much research. Undoubtedly, chemical and physical changes in nerve cells take place.
Does electroshock therapy work on all patients?
Electric treatment is most effective in depressed patients, but is frequently helpful in other kinds of mental illness in which depression is involved.
Do you find much use for electroshock therapy in the future?
At present, we still require electric treatments for some illnesses, but every month, it seems, our skill with drugs and the drugs available become more efficient, so that it begins to look reasonable to expect a time to come when drugs will replace electroshock and insulin.
Thank you, Dr. Goldman. Today, we have looked at some organic treatments which have been used extensively and are still being administered to the mentally ill. Psychosurgery, a controversial, though at times effective method of dealing with mental illness, is being used very, very little. Now, insulin and electroconvulsive therapies are being applied also less frequently, to a point where hospitals which once gave electroshock at the rate of 100 or 150 times a week are now giving just 4 or 5 treatments per week. The reason for this short drop in demand is the availability to psychiatry of the new drugs. We have invited Dr. Goldman back to discuss the remarkable change these drugs have produced in patients and in the atmosphere of the mental hospital. Until then, thank you and goodbye.